Hello, my name is Carolyn Abbott, and this is case study number 57, hyperthyroid disease for nurse 711, advanced physiology and pathophysiology. BG is a 52-year-old man who was brought to the emergency room by paramedics for symptoms of dyspnea, dizziness, and palpitations. Chief complaint: I was jogging in the park like I do most mornings. Suddenly I couldn't catch my breath and I felt very dizzy. When I sat down on a park bench for a few minutes, I noticed a weird feeling in my chest, like a strong fluttering sensation. I called 911. BG reports an unintentional weight loss of approximately 10 pounds over the past 2 months and close to 15 pounds over the past 4 months. Patient states he has been eating like an elephant but still losing weight. He reports that a few months ago he began experiencing palpitations that are not associated with chest pain. He also notes that the palpitations are disproportionate to any activity he is engaged in. He states that mentally he has not been himself. Hyperthyroidism is characterized by the excess production and release of thyroid hormone by the thyroid gland. This disproportionately high level of the hormone leads to an accelerated metabolic state. Hyperthyroidism presents as either overt or subclinical. Overt is defined as low or suppressed TSH with elevated T3 and or T4. And subclinical hyperthyroidism is defined as low or suppressed TSH with normal T3 and T4 levels. Symptoms include increased sweating and feeling hot, feeling like your heart is racing or is beating irregularly, hand tremors, anxiety, nervousness, and irritability, weight loss despite normal or even increased appetite, frequent bowel movements or diarrhea, difficulty sleeping, hair loss, changes in menstrual periods, often lighter and or less frequent, trouble swallowing or fullness in the neck, increased or decreased energy level, and pain behind the eyes and or swelling or bulging of the eyes. The most common causes of excessive production of thyroid hormone includes grave disease, toxic multinodular goiter, and toxic adenoma. The most common cause of an excessive passive release includes thyroiditis, anti-thyroid medications, and thyroidectomy. In the U.S., the prevalence of hyperthyroidism is 1.2%, and Graves' disease is the most common cause. Hyperthyroidism is more common in women. Risk factors that are associated with the development of hyperthyroidism includes genetics, iodine deficiency or excess, and smoking. Graves' disease is highest in those between the ages of 30 to 50. Toxic multifocal and toxic adenoma or plumber's disease is more prevalent in older adults. Autoimmune disorders are more common in iodine replete areas, while nodular thyroid diseases are more common in iodine deficient areas. The production and release of thyroid hormones is regulated by a negative feedback loop involving the hypothalamus, pituitary gland, and thyroid gland. The hypothalamus releases thyroid releasing hormone, which in turn stimulates the pituitary to release TSH, stimulating the thyroid gland to release thyroid hormones T4 and T3. The increased production of thyroid hormone normally causes inhibition of TRH and TSH. Disruption of this system leads to additional production and release of thyroid hormone and subsequent hyperthyroidism. The pathophysiology of hyperthyroidism depends on the causative variant. Graves' disease is an autoimmune process that causes antibodies to be formed against the TSH receptor. The antibodies stimulate the TSH receptor, which leads to increased production of T3 and T4, enlarged thyroid, and increased iodide uptake. Toxic multinodular goiter involves autonomously functioning nodules in the thyroid that arise from the replication of clonogenic cells. This leads to somatic activating mutation of TSH receptors. TMNG is more common in third world countries and in the elderly with poor dietary iodine intake. Toxic adenoma is a single hyperfunctioning nodule that produces a surplus of thyroid hormone and is due to iodine deficiency. Mr. G was brought to the emergency room due to symptoms of dizziness, dyspnea, and palpitations. He reports a 10-pound unintentional weight loss over the past 2 months and nearly 15 pounds over the last 4 months. He states he has been eating like an elephant but is still losing weight. A few months ago, he began experiencing palpitations that came and went, but were not associated with chest pain. He notes that his heart seems to beat too fast and too hard, regardless of what he is doing at the time. He also reports that he has noticed some difficulty swallowing certain kinds of food for the past week. He has noticed that his hair seems to be falling out faster than usual for the past month. His wife has told him that he has been on the edge and short with her lately. Past medical history includes migraines times 9 years, a history of herpes simplex infections, and hypertension times 3 years. Family history: his paternal grandfather and father were diagnosed with prostate cancer. His half-sister has thyroid problems with a goiter. His mom had arthritis and hyperthyroidism, and he has a brother with type 2 diabetes. He's been married for 30 years, and he had one daughter who was kidnapped and murdered 6 months ago. He works as an auto mechanic. He quit smoking 11 years ago, drinks beers occasionally, and reports a history of heroin and cocaine use as a young adult. He states he's physically active. His medications include acetaminophen, aspirin, and caffeine PRN, atenolol 25 milligrams, multivitamins, and he is allergic to morphine. Mr. G is a thin, tanned white male who appears to be mildly short of breath. He has hyperpigmented lesions on his upper back and lower extremities. His hair is fine, velvety, and sparse on the crown of his head. He has bilateral eye lag. The right is greater than the left. He has mild ptosis bilaterally, a cold sore on the right upper lip, an irregular rhythm with a rapid pulse at 130 to 170. His thyroid panel was abnormal with a total T3 of 580, total T4 of 26.5, free T4 of 57, and a TSH of 0.016. His ECG shows that he is in AFib with a rapid heart rate. Radioactive iodine uptake showed 53% absorbed after 5.9 hours. His TSH receptor antibody test positive, and his exophthalmometry is greater than 20% in the right eye and greater than 11% in the left eye. The role of the APN. Faith continues to have a strong influence on advanced practice nurses and is pervasive in every aspect of their lives. It allows the APN to provide spirit-guided care, holistic care that is designed to provide optimal patient-centered care. Spiritual care is defined by a compassionate presence and listening in order to help the patient make meaning out of their experience. It is always important to consider the personal preference of the patient to be considered as you work together to decide on a plan of treatment. The best approach for treating hyperthyroidism depends on the patient age, their health, the underlying cause, and their personal beliefs. And as APNs, we must always remember God is the source of all healing. Behold, I will bring health and healing. I will heal them and reveal to them the abundance of peace and truth. Jeremiah 33:6. And here are some additional questions for you to consider. What is the cause of hyperthyroidism disease in this patient? Identify the single greatest risk factor for hyperthyroid disease in this patient. And why can a thyroid adenoma be excluded as a potential cause of hyperthyroid disease in this patient? The following slide includes the references, and I thank you for your time.